Hi friends, I am Dr.N.Sriram. Today I will explain about factors influencing drug absorption.
Factors affecting dissolution and dissolution rate. Physicochemical properties of drug. 1. Solubility. 2. Particle size. 3. Polymorphism. 4. Salt formation. 5. Complexation. 6. Wettability. Dosage form factors, formulation factors and excipients. Biological factors. Gastrointestinal physiology. Gastrointestinal blood flow. Gastrointestinal pH. Gastric emptying. Effect of food on drug absorption. Malabsorption. Dosage form factors. Patient-related factors. Age. Gastric emptying time. Intestinal transit time. Gastrointestinal pH. Disease state. Blood flow through GIT. GI contents. Pre-systemic metabolism. Particle size and surface area of drug. Absolute surface area, total area of solid surface. Effective surface area, area of solid surface exposed. Micronization, 0.1 increase energy and increase interaction, increase surface area and dissolution rate. Micronization of non-hydrophobic drugs, poorly AQ. Soluble drugs increase dissolution rate. Example, griseofulvin, chloramphenicol, and tetracycline. Particle size and surface area of drug, continued. Decrease dose of griseofulvin to half and spironolactone 20 times. Hydrophobic drugs, decrease effective surface area and decrease dissolution rate. Adsorb air on surface and inhibit wettability and float on medium. Reaggregate to form a larger particle due to high surface energy, settle or float. Production of surface charge prevent wetting. Particle size and surface area of drug. Micronization of unstable and degradable drugs like penicillin G and erythromycin not increase dissolution rate and produce undesirable effects. Nitrofurantoin. Polymorphism and amorphism. Polymorphism, substance in more than one crystalline form. Differ in solubility, melting point, density, hardness. Polymorphism and amorphism. Stable, low energy, high melting point least aqueous solubility. Metastable, high energy, low melting point and high aqueous solubilities, better bioavailability. Example, chloramphenicol palmitate B, ABC. Riboflavin 3, I2-3. Stable to metastable, by dehydrating the molecular environment, by adding viscosity building agent like PVP, CMC. Amorphous, high aqueous solubility. Example, amorphous form of novabiocin, chloramphenicol, cortisone acetate, and phenobarbital. Amorphous metastable stable. Hydrates/solvates. Solvates, molecular adduct where the solvent molecules are incorporated in crystal lattice. Hydrates, solvent water. Anhydrous form, high energy state greater aqueous solubility. Example, theophylline and ampicillin. Organic solvate, more aqueous solubility than non-solvate. Example, N-pentanol solvate of fludrocortisone. Chloroform solvate of griseofulvin. Salt form of the drug. Solubility is pH dependent. Weak acidic drug, strong base salt prepared. Solubility in diffusion layer is greater. Higher pH favors solubility of weak acid. Example, Na and K salt of barbiturate and sulfonamide. Weak basic drug, strong acid salt prepared. Example, HCl salt of alkaloids. Solubility in diffusion layer is greater. Lower pH favors solubility of weak base. Salt form of the drug. Increased solubility is due to precipitation of drug as very fine particles in bulk solution. Size of the counter ion of the drug also influence solubility, small size high solubility. Novabiocene NaCa acid 50:25:1. More soluble salt, poor bioavailability. Na-phenobarbital free phenobarbital. Due to not disintegration of the tablet. Drug stability. Poor bioavailability due to destabilization of drug during its shelf life is due to degradation of drug into inactive form. Interaction with one or more different component. Drug pKa and lipophilicity and GI-pH. pKa, pH of fluid at absorption site, function of unionized drug. Strong acid, low pKa, greater proportion of ionized drug. Strong base, high pKa. Drug pKa and lipophilicity and GI-pH. Very weak acids, pKa 8 unionized at all pH values, absorbed along the entire length of GIT, pH 1 to 8. Example, phenytoin, phenobarbital. Moderately weak acids, pKa 2.5 to 7.5 unionized in gastric pH, ionized in intestinal pH, better absorbed from stomach. pH 1 to 3. Example, aspirin. Ibuprofen. Stronger acids, pKa 2.5 ionized at all pH, poorly absorbed from GIT. Drug pKa and lipophilicity and GI-pH. Very weak bases, pKa 5 unionized at all pH values, absorbed along the entire length of GIT, pH 1 to 8. Example, theophylline, caffeine, diazepam. Moderately weak bases, pKa 5 to 11.0 ionized in gastric pH, unionized in intestinal pH, better absorbed from intestine, pH 5 to 8. Example, reserpine, codeine. Stronger bases, pKa greater than 11 ionized at all pH, poorly absorbed from GIT. How does pH vary in the body? So the same compound will be ionized to different extents in different parts of the body. This means that, for example, basic compounds will not be so well absorbed in the stomach than acidic compounds, since it is generally the unionized form of the drug which diffuses into the bloodstream. Biological factors. Biological factors. Gastrointestinal physiology. Gastrointestinal blood flow. Gastrointestinal pH. Gastric emptying. Effect of food on drug absorption. Malabsorption. Physiology of GIT. GIT comprises of no of components. Stomach. Small intestine. Large intestine. The primary functions of GIT are secretion, digestion, absorption. Gastrointestinal physiology. Stomach. It is a pouch-like structure lined by smooth epithelial membrane. Absorption of weakly acidic drugs or unionized drugs and weak basic drugs takes place. Small intestine. Generally carrier-mediated transport is seen in most drugs. Proximal part absorption of dietary constituents includes monosaccharides, amino acids, vitamins, minerals etc. Ileum VITB12, bile salts. Microvilli. The effective surface area can be made 10 times larger to that of stomach because of the presence of microvilli. These are finger-like projections arising from and forming folds in intestinal mucosa. Effective surface area was decreasing from proximal part to distal part of small intestine. Large intestine. It is not an effective site. Incomplete absorption was occurred when large amount of drug reaches colon. It's an area of absorption of escaped drug. It was recommended for certain drugs whose metabolism occurred by intestinal bacteria for bioactivation. Blood flow plays a major role in absorption by continuously maintain the concentration gradient across the epithelial membrane. Absorption of polar molecules doesn't depend on the blood flow. Rate of drug absorption is unaffected by mesenteric blood flow. Absorption of lipid-soluble molecules highly depends on the blood flow. Enter blood-liver systemic circulation. Gastrointestinal pH. pH varies according to the site. Many drugs are weak organic acids or bases, so pH is the IMP factor. Gastric fluid retards weak basic drugs and promotes weakly acidic drugs. Gastric secretions having pH less than 1. It varies because of diet and dilution. Some drugs, penicillin, undergoes degradation because of pH. This can be rectified by prodrug preparation. Example, penicillin carindacillin. Erythromycin's folate. Gastric emptying. The passage of food from the stomach to the small intestine is called gastric emptying. This process increases the bioavailability of the drug because mostly the absorption occurs in small intestine. Slow gastric emptying can delay the onset of effect of the drug. Example, analgesics and sedatives. Delayed gastric emptying is recommended when food promotes drug dissolution and absorption. Example, gresofulvin. Drugs irritate gastric mucosa. Example, aspirin, phenylbutazone. Drugs are absorbed from the proximal part of the small intestine and prolonged drug absorption site is desired. Example, vitamin B1, 2 and C. Gastric emptying is recommended when rapid onset of action is desirable. Example, sedatives. Dissolution of drug occur in the intestine. Example, enteric-coated dosage forms, which are not suits to gastric fluids. Example, penicillin and erythromycin. Drug is best absorbed from the distal part of the small intestine. Example, vitamin B1, 2. Factors affecting gastric emptying. Volume of meal. Drugs. Posture. Composition of meal. Physical state. Temperature. pH. Disease state. Effect of food on drug absorption. Food has an unpredictable effect which is irreversible. Food stimulate hepatic blood flow, which have implication for the bioavailability of the drug. Food tends to decrease the rate of gastric emptying, which affects drugs like penicillin. Forms poorly soluble and unabsorbable complexes. High protein food causes poor absorption of drugs. Example, levodopa. High fat food causes poor absorption of drugs. Example, isotretinoin. Administration of drug with large fluid volume enhances the dissolution rate and gastric emptying. Malabsorption. It is a disorder with impaired absorption of fat, protein, carbohydrate, vitamin, minerals and water. Drugs which induce malabsorption. Neomycin. Phenytoin. Aminosalicylate. These drugs mainly damages the gastrointestinal epithelium, emphasis the function of mucosa to serve as a barrier to large polar molecule. Dosage form factors. Disintegration time. Coated tablets, long disintegration time. DT, amount of binder. Hard tablet with high binder, long disintegration time. DT and disintegrant. Manufacturing/processing variables. Excipients, non-active contents. MFG processes. Method of granulation. Wet granulation, faster dissolution. Limitations. Formation of crystal bridge. Liquid may act a medium for chemical reactions. Drying may harm thermolabile drugs. Compression force. Direct compression, faster dissolution. Intensity of packing of capsule contents. Manufacturing/processing variables. High compression force. High density. Greater hardness. Low porosity. Low wettability. Slow dissolution rate. Manufacturing/processing variables. High compression force. Deformation. Crushing of drug particle into smaller, spherical shape to disc shape particle. High effective surface area. High dissolution rate. Intensity of packing of capsule contents. Can inhibit or promote dissolution. Diffusion of GI fluids into tightly packed capsules creates high pressure within capsule, resulting in rapid burst and dissolution of contents. Capsule with finer particles and intense packing have poor release and low dissolution rate due to low pore size and poor penetrability by the GI fluids. Excipients. Excipients imparts acceptability, physicochemical stability, uniformity of content, and optimum bioavailability. Vehicle. Diluents, colorants. Binders and granulating agents. Disintegrants, emulsifiers. Lubricants, surfactants. Coatings, buffers. Suspending agents. Vehicles. Aqueous, water, syrup, rapid absorption. Solubilizers, polysorbate 80, promote solubility of AQ. Vehicles. Non-aqueous water miscible, propylene glycol, glycerol sorbitol better bioavailability. Non-aqueous water immiscible, vegetable oils absorption depends on partitioning from oil to water phase. Viscous vehicles, slow absorptions. Diluents. Organic, carbohydrates like starch, lactose, MCC etc. Hydrophilic powder promote absorption of hydrophobic drug like spironolactone and triamterene by forming hydrophilic coat. Inorganic, dicalcium phosphate. Drug diluent interaction tetracycline plus dicalcium phosphate equals divalent calcium tetracycline complex, poorly soluble. Binders. Aqueous show better dissolution profile with poorly wettable drugs like phenacetin. Large amount of binders, high hardness takes more disintegration time/dissolution. PEG 6000 forms poorly soluble complex with phenobarbital. Non-aqueous, ethyl cellulose retard dissolution. Disintegrants. Disintegrants, hydrophilic. Small AMT of disintegrants, low bioavailability. Adsorbing disintegrants, bentonite, Vegum, avoided with low-dose drug, digoxin, since large AMT of drug is permanently adsorbed and only fraction of it is available for absorption. MCC is very good binder and disintegrants, but at high compression force it retards drug dissolution. Lubricants. Commonly used hydrophilic in nature, metallic stearate and waxes. Inhibit wettability, penetration of water into tablet and their disintegration and dissolution. Because disintegrants get coated with lubricants, can be prevented by adding lubricants in final stage. Use soluble lubricants like sodium lauryl sulfate and carbo waxes which promote drug dissolution. Coatings. Enteric coat, sugar coat, non-enteric film coat. Dissolution profile may change on aging. Shellac-coated tablets, on prolonged storage, dissolves more slowly in intestine. Prevented by adding little PVP in the coating formulation. Suspending agents. Popular suspending agent, hydrophilic polymers. Vegetable gums, acacia, tragacath etc. Semi-synthetic gums, CMC, MC. Synthetic gums. Macromolecular gums form unabsorbable complexes with drugs, CMC with amphetamine. High viscosity acts as a mechanical barrier to the diffusion of the drug by forming a viscid layer on the GI mucosa. Surfactants. Used as wetting agents, solubilizer, emulsifier. Enhance or retard drug absorption by interacting with drug or membrane or both. Increase absorption by promoting wettability, polysorbate 80 with phenacetin. Better membrane contact of drug for absorption. Enhance membrane permeability of the drug. Increase absorption by above CMC form unabsorbable drug micelle complex. Large surfactant concentration induce laxative action. Buffers. Buffers containing K and inhibit absorption. VITB12, sulfanilamide, by the uptake of fluid by the intestinal epithelial cells and decrease effective drug concentration in tissue. Order of inhibitory effect. KNH4-Li. Complexing agents. Complexed drug may alter stability, solubility, molecular size, partition coefficient, and diffusion coefficients. Complex formation enhance drug bioavailability by enhancing dissolution by forming soluble complex. Ergotamine tartarate caffeine complex, hydroquinone digoxin complex. Enhancing lipophilicity for better membrane permeability, caffeine PABA complex. Enhance membrane permeability, enhance GI absorption of heparin in the presence of EDTA which chelates Ca and Mg ions of membrane. Complexing agents. Complexation retard drug absorption by forming poorly absorbable complex, complexation of tetracycline with divalent and trivalent cations. Complex formation retard drug bioavailability by failure to dissociate at the absorption site. A large molecular size of the complex that cannot diffuse through the cell membrane, drug-protein complex. Colorants. Even a very low concentration of water-soluble dye can inhibit dissolution rate of several crystalline drugs by adsorbing onto the crystal faces. Example, brilliant blue retards dissolution of sulfathiazole. Dyes also inhibit micellar solubilization and impair absorption of hydrophobic drugs, steroids. Nature and type of dosage form. Difference in bioavailability depends on nature and type of dosage form. It is due to difference in relative rate at which the dosage form release drugs. The release rate depends on complexity of dosage form. More complex dosage form, more number of rate limiting step. Bioavailability of various dosage forms, solutions, emulsions, suspensions, capsule, tablets, coated tablets, enteric coated, sustained. Solutions. Drug in solution rapidly absorbed. Nature of solvent, viscosity, solubilizer, surfactants, stability etc. influence bioavailability. Stability, solubility, taste, cost limit the formulation of a drug in solution form. Emulsions and suspensions. Emulsions are superior than suspension in administration of poorly soluble lipophilic drugs. Example, emulsion of indoxil, anti-inflammatory, increases threefold absorption over suspension. Particle size, polymorphism, wetting agent, viscosity, suspending agents influence the bioavailability of suspensions. Powders. They are superior to tablets and capsules. Particle size, polymorphism, and wettability affect the absorption of the drugs. Capsules. Powders and granules, hard gelatin capsule. Viscous fluids and oils, soft elastic shells. Factors affecting hard gelatin capsule, particle size, density, polymorphism, intensity of packing, diluents and excipients. Hydrophilic diluents, lactose, improve wettability, deaggregation and dispersion of poorly aqueous soluble drugs. Hydrophobic lubricants, mg stearate, give inhibitory effect. A hydrophobic drug with fine particle size cause clumping of particle by decreasing porosity and hence penetrability of solvent. Capsules. This can be overcome by incorporating hydrophilic diluent, up to 50%, small amount of wetting agent/lubricants, SLS, up to 1%, and by wet granulation. Soft elastic capsules dissolve faster. Example, Indoxil. Soft gelatin capsules are prepared when the dose is low and drug is lipophilic. Limitations: high water content of the shell, greater than 20%, migrate into the shell content and crystallization of the drug occurs during drying stage. Coated tablets. Coating act as a barrier. Film coat, thin and dissolve rapidly. Sugar coat, tough and takes longer time to dissolve. Sealing coat of shellac is most deleterious. Enteric coat, dissolve only in alkaline pH and thickness of the coat is determinant factor in drug dissolution. Aging of shellac-coated tablets also affect drug release. Example, shellac-coated tablets of salicylic acid stored for 2 years showed 60% decrease in peak plasma level. Sustained release products. Drug release from such product is most unpredictable. Patient-related factors. Age. Gastric emptying time. Intestinal transit time. Gastrointestinal pH. Disease state. Blood flow through GIT. GI contents. Pre-systemic metabolism. Age. In infants, gastric pH is high and intestinal surface and blood flow is low. The cause of impaired drug absorption in adults: altered gastric emptying time, decreased intestinal surface area and GI blood flow, higher incidence of achlorhydria. Gastric emptying. Passage from stomach to small intestine, rate limiting step, most absorption occur from intestine. Gastric emptying is advisable where rapid onset of action desired, sedative. Dissolution of drug occur in intestine, enteric coated. Drugs are unstable in gastric fluids. Penicillin G, erythromycin. Drug is best absorbed from the distal part of small intestine. Vitamin B12. Gastric emptying. Delay gastric emptying is advisable where food promote dissolution and absorption. Griseofulvin. Gastric fluid promote disintegration and dissolution. Drug dissolve slowly, griseofulvin. The drugs irritate gastric mucosa, aspirin. Drugs absorbed from proximal part of the small intestine. Vitamin C, vitamin B12. Factors influence gastric emptying. Volume of meal, high volume, longer emptying time. Composition of meal. Carbohydrate, proteins, fats. Physical state and viscosity of meal. Liquid meal 1 hr, solid meal 6 to 7 hr. Temp of meal, high or low temp, longer time. Gastrointestinal pH, low pH, long time. High pH, low time. HCl, acetic, lactic, tartaric, citric. Factors influence gastric emptying. Electrolyte and osmotic pressure. Water, isotonic solutions and low salt concentration, rapid emptying. Higher electrolyte concentration, slow emptying. Body posture, standing, rapid, lying on right side, lying on left side. Emotional state, stress and anxiety promote gastric motility while depression retards it. Exercise, vigorous exercise retards gastric emptying. Factors influence gastric emptying. Disease state. Gastroenteritis, gastric ulcer, diabetes and hypothyroidism, retard gastric emptying. Gastrectomy, duodenal ulcer and hyperthyroidism, promote gastric emptying. Drugs. Poorly soluble antacids, anticholinergics, narcotic analgesic, and tricyclic antidepressants, retards gastric emptying. Metoclopramide, domperidone, cisapride, promote gastric emptying. Intestinal transit time. Small intestine is major site for drug absorption. Long intestinal transit time is desired for complete drug absorption. Residence time depends upon intestinal motility or contraction. Peristaltic contraction promote drug absorption by increasing the drug-intestinal membrane contact, by enhancing drug dissolution. Pregnancy retard intestinal transit whereas diarrhea promotes it. Intestinal transit time. Metoclopramide, laxative, promote intestinal transit time and enhance absorption of rapidly soluble drugs. Anticholinergics retards gastric and intestinal transit and promote absorption of poorly soluble drugs. Intestinal transit time. Delayed intestinal transit is desirable for drugs that release slowly, sustained release. When the ratio of dose to solubility is high. Chlorothiazide. Drugs that dissolve only in intestine, enteric-coated. Drugs which are absorbed from SP site in the intestine, lithium, carbonate, vitamin B. When drug penetrate the intestinal mucosa very slowly, example, acyclovir. When absorption of drug from colon is minimal.